Thank you for joining us today. We'll start the session at 5. Good evening, everyone. Thank you for joining today's masterclass on examination of hip joint by Dr. Alok Sud. I, Sumita Roy, with my colleague Shruti Jain from the marketing team of Elsevier India, will be moderating the session today. Before we begin, I would like to tell all the attendees that you will not be able to unmute yourself during this session. Should you have any questions related to the topic in discussion, You can post them in the Q&A tab on your screen. These questions will be addressed by Dr. Sood at the end of his session. And now, it is my honor to introduce you to our esteemed speaker today. Dr. Alok Sud is the Director Professor in Orthopaedics at the prestigious Lady Hardinge Medical College, New Delhi, and is one of the senior most faculties of orthopedics in Delhi University. He was trained in Delhi and did a fellowship at Royal Hospital for Sick Children, Edinburgh. He has 23 years of experience in teaching undergraduate and postgraduate students, along with major clinical practice. He has special interests in the field of pediatric orthopedics, limb construction, and spinal deformities. He runs special weekly clinics for clubfoot treatment and gait clinic for spastic children and children with special needs in the renowned Kalavati Saran Children's Hospital. He has published over 30 scientific articles in various international and national journals. Besides being the author of textbook of orthopedics for undergraduate students, he has contributed chapters to several prominent PG books in orthopedics. He is the associate editor for the Journal of Clinical Orthopedics and Trauma, the official journal of Delhi Orthopedic Association, and has been the co-opted member for Indian Journal of Orthopedics. He is life member of Delhi Orthopedic Association, Indian Orthopedic Association, ASSAMI, Association of Hand Surgeons of India, and Pediatric Orthopedic Surgeon Association of India. He is also the founding member of Pediatric Orthopedics Foundation, the official pediatric orthopedic body of Delhi, and was member of former MCI in the year 2018-19. And with that, I request Sir to please take this forward.
Thank you, Sumita, for all the kind words. Dear students, good evening. I have deliberately chosen this class today on hip joint examination because I know its importance in undergraduation as well as in post-graduation if you want to pursue orthopedics in your post-graduation. So let us begin with the hip joint examination class. Before we go on to examination, let us know about the relevant anatomy. Now we all know that the hip joint is composed of the proximal femur, right? And the ilium. Can you see my cursor? Right. Now this innominate bone is composed of ilium, the red one, pubis, the yellow one, and ischium, the green one. All these three bones, they contribute to the formation of vestibulum, and this vestibulum, it articulates with the proximal femur to give rise to hip joint. Now, the stability of the hip joint is contributed by the bony architecture, that is its ball and socket architecture, which is deepened by the presence of acetabular labrum, as well as by capsule and ligaments. Before we go on to capsule and ligaments, we must know about the geometry of the hip joint. Now, it is important to know the geometry of the hip joint because so that we can naturally align the fractures of the proximal femur. And this geometry also helps us in understanding the planning and design of the total hip arthroplasty implants. So number one is that you must have seen is that the proximal neck is aligned at an angle to the shaft. This is called neck shaft angle, and it is approximately 127 degrees in adults. Not only the neck is aligned at the neck shaft angle, it is also aligned slightly obliquely as compared to the baseline which is formed by the femoral condyles. So if this is the line which represents the femoral condyle, so the proximal femur is aligned at an angle of approximately 15 degrees to this. This 15-degree angle is called femoral anteversion. Similarly, the acetobulum does not look entirely anteriorly or entirely laterally. It looks anterolaterally so as to give it an anterolateral anteversion of approximately 20 degrees. So these three angles are important. Not only that, if you will see in this figure, the acetobulum is tilted approximately in this plane at approximately 45 degrees to the baseline. So there are two angles to the acetobulum and there are two angles to the femur which you must remember. Now coming to the ligaments of the hip joint, it is very easy to understand the names of the ligaments of the hip joint. There are three major ligaments, those which are connecting the ilium with proximal femur, iliofemoral, the famous ligament of Bigelow. This is the strongest ligament in the body. the one connecting the ischium and proximal femur, the ischiofemoral ligament, and the other one, this blue one, which is connecting the pubis and femur, the pubofemoral ligament. The other ligaments of the hip joint are the transverse ligament, this one, which completes the circle of the acetylbulum, and the round ligament, which is also called ligamentum teres. Now, these ligaments, along with the muscles, they stabilize the hip joint. The muscles, they not only stabilize the hip joint, they also move the hip joint. So, for various movements of the hip joint, we require muscles. For example, for flexion, the primary flexor is the iliopsoas. Extensors, the primary extensor is gluteus maximus. The primary abductor is gluteus medius. The primary adductors are three: adductor brevis, longus, and magnus, as you know. External rotators, the muscles which are present posteriorly are external rotators. They include short external rotators besides uh, uh, gluteus maximus, and internal rotators. These are anterior fibers of gluteus medius, minimus, and tensor fasciae lata. So, with the help of ligaments and muscles, not only the hip joint is stabilized, but muscles also move the hip joint. You must remember that. Now, it is important to know the blood supply of the hip joint. That is because most of the arteries which are supplying the proximal femur are end arteries. So, whenever there is a fracture of the neck of femur, the fracture of the neck femur also results in break in the arteries of the arteries which are supplying the proximal femur. And because these are end arteries, there is no anastomosis over here. Therefore, injury to these arteries results in avascular necrosis. So, the blood supply comes from profunda femoris. Profunda femoris gives rise to two arteries, the lateral circumflex and the medial circumflex, which form a circle at the base of the neck. From this circle arise retinicular vessels which supply the neck as well as the head. So that is why it is important to understand the blood supply. Now, hip joint is a deep joint. It is not a superficial joint like knee joint or elbow joint. If it is a superficial joint like elbow, you can directly palpate the joint line. But since hip is covered on all sides by deep muscles, that is why it is important to know its surface anatomy, because we cannot palpate its joint line directly. So what tells us its anatomy? Its anatomy, its surface anatomy is indicated by this important Scarpa's triangle, which you all of you have studied during your anatomy days. It is formed by, the base is formed by the inguinal ligament, right? Its medial arch is formed by, the medial border is formed by the adductor longus, and the lateral border is formed by sartorius, right? So this is sartorius, this is the adductor longus, and this is the base of the base is formed by the inguinal ligament. So the hip joint lies approximately in the middle of the at the middle of the mid-inguinal point, right? So what is mid-inguinal point? Mid-inguinal point is the line which joins the symphysis pubis medially and anterosuperior iliac spine laterally. See, it is different from midpoint of the inguinal ligament, which is the midpoint which joins the pubic tubercle and ASI spine. So whenever we talk about surface anatomy of the hip joint, it is with relation to the mid-inguinal point. So for palpation, for aspiration, the landmark is taken to be 2 centimeters below and lateral to the mid-inguinal point. Now, this mid-inguinal point is also depicted by the femoral artery pulsation. So, if you do not have anything to measure, you can just palpate for femoral artery and just go 2 centimeters below and lateral to the femoral artery where it crosses the inguinal ligament, and you will reach the surface of the hip joint. Now, once we know the surface anatomy of the hip joint, let us come to the normal range of motion of the hip joint in an adult. So the flexion at the hip is 0 to 90 degree with knee extended. You can think in your mind that with knee flexed, obviously the flexion will be much more, right? So till the thigh touches the abdomen, which is approximately 120 to 130 degrees in adults. The extension is 0 to 15 degrees, abduction is 0 to 40 degrees, adduction is 0 to 30 degree, external rotation till 45 degrees, and internal rotation from 0 to 30 degrees. Now, it is important to know that all these movements, the abduction, adduction, external rotation, and internal rotation, they all increase in flexion, right? That is because in extension, the hip joint is the capsule of the hip joint is stretched, whereas in flexion, the capsule of the hip joint is relaxed. It gives more room for the bones to move, and that is why these movements are more in flexion. Now, once we know about the relevant anatomy and physiology, let us come to the history. Now, the clinical examination should be preceded by relevant history, and most common history points which are there in hip joint examination are pain and limb, right? So the pain is usually present in the base of the scarpus triangle and it is referred to knee. That is because of the common nerve supply due to obturator nerve and femoral nerve. The second most important sign is limb. And as you must have heard, that night cries, they commonly happen because of destruction of the articular cartilage, especially because of the tuberculosis. What happens is that, especially in children, that once there is tubercular arthritis and the child sleeps, the inflamed joint margins, they rub against each other because the spasm of the muscle during sleep is lost, and that results in pain during sleep, and these are called night cries. So these are the relevant history points. Now, coming to the diagnostic calendar, this diagnostic calendar is modified uh, according to the Indian scenario. From 0 to 5 years, the most common presentation, the most common pathology which presents to us is a developmental dysplasia of hip. 5 to 10 years, most common is Perthes disease. 10 to 15 years, it is slipped capital femoral epiphysis, and 20 to 40 years, it is inflammatory arthritis. 40 years and above, it may be osteoarthritis, which is usually secondary in Indian patients, and less of primary osteoarthritis is seen because most of us are habitual of squatting. So primary osteoarthritis is rarity in Indian patients, but you must have noticed that tubercular arthritis is prevalent in all age groups, right? So in Indian patients, a tubercular arthritis of the hip is almost always the differential diagnosis. Now coming to the examination proper. Now, whenever the patient comes to you in your clinic, a seasoned examiner, to save his time, will always start examination while the patient is walking into his clinic. So you focus on the gait of the patient. Now, the various symptoms like pain, limb length discrepancy, instability, or fused hip can result in an abnormal gait. Pain usually results in an antalgic gait. Now, antalgic gait is something where the stance phase on the affected site is reduced. Suppose the right-sided hip is painful, so the patient will try to diminish his stance phase on the right side and will try to shift the weight quickly on the left side. So that is an antalgic gait. When there is limb length discrepancy, you can see a short limb gait. Suppose the right lower limb is short than the left. So when the child is walking or the patient is walking, the shoulder and pelvis will dip vertically down when the patient is walking. This is short limb gait. Instability is shown by Trendelenburg gait. We will discuss this gait in the next slide. And when the hip is fused, that means there is no movement at the hip joint. The ground clearance is gained by lifting the pelvis instead of flexing the hip. So there will be a circumduction gait, right? Now coming to this very important Trendelenburg test, which results in the gait of the same name. Now you just focus on this figure on the left hand side, and we assume that in this figure both the hips are normal. Now suppose when the child or the patient is walking, he will alternatively shift his weight from left to right. When his weight is on left side, his right lower limb will be lifted up in the air, right? When the lower limb is lifted up in the air, by the act of gravity, it should drop down. But it doesn't drop down because the abductors on the left side contract and make the pelvis level. Now, suppose that left-sided abductors are paralyzed. So what happens is that whenever he's bearing weight on the left side and the right side is in the swing phase, under the effect of gravity, this pelvis will drop down. The pelvis drops down, and it can be seen clinically by dropping down of the ASI spine or the PSI spine, the posterosuperior iliac spine. However, this results in much energy expenditure. To cut short the energy expenditure, the upper body tilts to the affected side. So when the upper body tilts to the affected side, so what happens is that there will be a lurch on the affected side to reduce this pelvic tip. So this is called Trendelenburg test, and this also results in Trendelenburg gait. So what happens in an unstable gait or Trendelenburg gait? The lurch presents on the same side. I hope you have understood it. So this unstable gait or this test is present in weak abductors, unstable fulcrum as in untreated developmental dysplasia, or dislocation of the hip joint, or disorders of the lever arm like in coxa vara or fracture neck of femur, And sometimes it also happens in painful conditions of the hip, which results in dysfunction of the abductor muscles. Now, once we have examined the gait, we come to the inspection. Inspection should always be started in standing position. So once we start inspection, the first thing to be inspected is the attitude. Now, attitude is what which reveals the compensation mechanism that happens above and below the hip to compensate for the pathologies of the hip joint. I'll give you an example to clarify it. For example, there is the patient has a short limb, right? A short right limb. So how will he compensate while standing the short right limb? By equinus of the ankle, right? He can lengthen, or by dipping up the pelvis on the affected side, or by extension of the hip and knee on the shorter side to make it apparently longer, or flexion of hip and knee on the longer side to make it apparently shorter. So all these mechanisms, compensatory mechanisms, will be revealed in attitude of the patient. So that is why at examination of the attitude or noting down the attitude during inspection is important. Once we have noted down the attitude, we come to the inspection of the patient in the standing position from front, behind, and side, right? So from back, you see from back as well as front, you see the head, right? The level of shoulder and scapulae, the spine in coronal plane. Coronal plane means you will be able to see the lateral curvature of the spine like scoliosis. Iliac crests and posterior iliac spines are seen from the back. Gluteal folds are seen, popliteal creases are seen, and levels of heels are seen. So this is all seen from the back. From front, you will be able to see the level by comparing the shoulders and nipples, anterosuperior iliac spine, abdominal creases, the level of patellae, and the level of malleoli. From the side, you will be able to see the spinal curvature in the spine in the sagittal plane. Now, what spinal curvature exists in the sagittal plane? It is lordosis and kyphosis. Now, both dorsal kyphosis and lumbar lordosis up to an extent are normal in the sagittal plane. You will be also able to see flexion at the knee and equinus of the ankle more clearly from the side. Now, once we have examined the spatial relationship and the compensations which have happened because of the pathologies of the hip joint, we come to inspection proper, which during which we see any telltale marks like scars, sinuses, swelling, dilated veins, bony prominences, wasting of the muscles, or prominence of the muscles, right? Now, similarly, once we have finished our inspection in the standing position, we inspect the patient in sitting position. Everything else is same, except that now whatever is compensatory will be gone. So suppose if the patient was standing with a compensated or with a pelvic tilt to compensate for his short limb, now that tilt will be gone. Level of ASI spine and on the both sides as well as posterior superior iliac spine on both sides will be compared and they will be found to be normal at the same level, right? I hope I am clear. Similarly, if the patient was compensating with the curvature of the spine, uh, that also will disappear. So such scoliosis or such curvature is called postural, which disappears on change of the posture. That is, it was present in standing position, but it disappears on sitting or lying down position is a postural scoliosis. Now, similarly, once we have inspected in standing and sitting position, now we inspect the patient in a lying down position. Again, we start with attitude. Suppose the patient is having flexion deformity. Now, when the patient is having flexion deformity of the hip joint, he may not lie down with flexion at the hip joint. So how will he compensate the flexion at the hip joint? He will compensate flexion of the hip joint by exaggerated lumbar lordosis, right? So that is the importance of seeing attitude. Similarly, if the limb is short, you'll be able to see different levels of patellae and malleoli. And similarly, rotational deformity may be indicated by position of the patella as well as position of the foot. Rest of the inspection points can also be re-examined while the patient is lying down. Now, once we have inspected carefully, we have also seen the gait. Now comes the palpation, right? Now, this is where I would like to recall your knowledge of surface anatomy. Now, where to look for temperature, right? So by the knowledge of surface anatomy, we know that hip joint is present somewhere at the base of the scarpus triangles. So you cannot see the bony architecture in a lying down patient. So you will have to imagine this uh, uh, imagine these structures by the knowledge of your surface anatomy. So first of all, you will see temperature at the base of the scarpus triangle. Then you see tenderness again at the base of the scarpus triangle, 2 centimeters below and lateral to the femoral pulses. You can also see tenderness by pressing upon the greater trochanters on both sides. This is called Morris bitrochanteric compression test. Swelling will be seen again most commonly in the scarpus triangle. Femoral head may be palpated posteriorly in posterior dislocations of the hip, which is the most common direction of the dislocation. Now, femoral artery pulsation can be seen, can be palpated just uh, just anterior below approximately 2 centimeters below and lateral to the mid-inguinal point. Now, if good volume femoral pulse is palpated, that means it has got a good firm surface against which it is palpated. However, if the hip joint is destroyed or if it is dislocated, that means a firm surface against which the pulse is felt is not present. So this results in diminution of the volume of the pulse, and this is called vascular sign of Neerath. Once we have palpated the hip joint and the pulses, we palpate for the greater trochanter for temperature, tenderness, surface, its surface, and thickening. Once we have also palpated the greater trochanter for temperature, tenderness, and its surface, we now come to the level of the greater trochanter, right? So by drawing a digital Bright's triangle, we can roughly know that which greater trochanter is up or which greater trochanter is below, right? So levels of the two trochanters can be compared with this test. So what you do is that you place both the thumbs, you ask the patient to lie down, you place both the thumbs on the ASI spines, and you place the fingers, the forefinger and the middle finger, on the tips of the greater trochanter. Now, with the help of this, you can judge approximately that which greater trochanter is up or which greater trochanter is low, and you can make a digital Bright's triangle in your mind. Obviously, later on, it will be measured with the help of a tape. Now that finishes with the palpation. This comes to the important part of deformities and movements, right? So what is the deformity? So deformity a, is a position which a joint holds in which further movement in the same plane is possible, but opposite movement is not possible. For example, the hip is held, a right hip is held in 20 degree of flexion deformity. That means that this hip is held in 20 degree of flexion. Further flexion is possible, but extension is not possible. So the deformities in sagittal plane can be flexion and extension deformities. In coronal plane, they can be abduction, adduction deformities. And in axial plane, these can be internal, external rotation deformities. There can be combination of these deformities. For example, flexion, adduction, internal rotation deformity. It commonly happens in tubercular arthritis. Now, how to look for these deformities? Now, uh, let's see this example. For the flexion, to reveal the flexion deformity, we do a Thomas test. Suppose the left hip is involved, right? So as I already told you, if the left hip is held in flexion, the patient will lie down with an exaggerated lumbar lordosis, right? So you already know that one of the hip is having flexion deformity. So what you do is that you ask the patient to flex the normal hip. So suppose left hip is involved in this patient, you ask the patient to flex the sound hip till the point the lumbar lordosis disappears. Once the lumbar lordosis disappears, by flexion of the sound hip, the left hip will be carried into flexion. And when this angle of flexion is measured, this will give us the plane of the degree of deformity with which the hip is held in flexion, right? So this has, I hope it is clear to you that we flex the normal hip, right? And see the movement in the opposite hip. Now, suppose if both the hips are involved, then what do we do? Then we do this test. We ask the patient to lie down prone at the edge of the table. Now, when both the legs are dangling down, the lumbar lordosis will be flat. Now, you gradually extend one of the limbs. When you gradually extend one of the limbs, the lumbar lordosis will just begin to appear. The point at which lumbar lordosis begins to appear is the measurement of the flexion deformity. This is called Stylus test. This can be repeated one by one in both the hips. Extension deformity is best tested with patient in lateral position or prone position. Uh, a patient with extension deformity will not have flexion movement. So remember this: extension deformity, no flexion; flexion deformity, no extension. Coming to the deformity in the coronal plane, this is very important. Now, I want you first to focus down on these two figures on the left hand side. Now, suppose this is the patient where the left hip is involved with tubercular synovitis. All of us know that in tubercular synovitis, the patient will have an abduction deformity. So when the patient is having abduction deformity, the limb should lie like this in abduction. But it will be rarely that the patient will rest in this position. It will be all the more rare for a patient to walk in this position. So when the patient with abduction deformity lies down in the bed, he will not keep his limb in abduction, but he will try to keep his limb parallel to the midline and parallel to the other limb, right? So once he tries to keep to make this abducted limb parallel to the other limb and to the midline, he will pull the pelvis down. Why will he pull the pelvis down? Because this is abduction deformity. So when there is abduction deformity, there will be no adduction possible. So when there is no adduction possible, the only way to bring it down is by movement of the pelvis. All right. So when you see a patient with left hip involvement with ASI spine dipping down on left side, this is abduction deformity. So how do you reveal this abduction deformity? It is simple. By abducting the same limb to a point till both the ASI spines are at same level. Okay. So the angle which this limb throws with the midline is the degree of the abduction deformity. So further abduction will be possible, but adduction will not be possible. Whenever you try to adduct it, it will be movement at the pelvis and not at the hip joint. Okay. So this method of bringing both the ASI spines at the same level is called scaring of the pelvis, right? Now, similarly, the adduction deformity. Now you focus at the figures on the right side. All of us know that the there is adduction deformity in a patient with tubercular arthritis. Let us assume that this patient on the left side, on the left hip, is suffering from tubercular arthritis, right? Now, in tubercular arthritis, there is adduction, but you will not see a patient who's resting or walking in an adducted position. So how will he rest or walk? He will have to make this limb parallel to the midline and parallel to the other limb. So when he does it, he will have to abduct it. But since there is adduction deformity, there is no abduction possible. Since there is no abduction possible at the hip joint, where the movement will happen, it will happen at the pelvis. And once he tries to parallelize both the limbs, he will have to lift the pelvis on that side. So left side pelvis is the ASI spine is lifted up. It means adduction deformity. And how to reveal this? You just adduct it, right? You just adduct it like this till the point both the ASI spines are at same level. And this angle which it makes with the midline will give us the degree of the adduction deformity, right? So I hope this concept is clear to you. Now, this can further be, this is the most common method to assess these deformities. Another common method which can be applied is the Kotharis method. What you do is that you do not scare the pelvis, right? What you do is that you join the two SI spines with the line, uh, and then you throw perpendiculars from one spine to the midline, right? From other spine to the midline, and you measure these angles. So these angles will give you the measurements of adduction deformity and abduction deformity. A third test is called Kynes test, right? So what it does is that you make two lines, one joining the ASI spines or the iliac crest, and the other joining the greater tips of the greater trochanter. Convergence on the affected site indicates abduction deformity because on that side the pelvis has lowered down, and divergence on the affected side will tell us about the adduction deformity because the pelvis on that side has lifted up, right? Morris bitrochanteric test, on the other hand, is the measure of distance in between symphysis pubis and greater trochanter, right? Symphysis pubis and greater trochanter. Now, this distance will be increased in anterior dislocation and will be decreased in posterior dislocation or central fracture dislocation. Coming to rotations. Now, rotations are very important to see. Rotations have to be seen in extension of the hip joint as well as in flexion of the hip joint. Right? When the hip joint is extended, the patient might be lying supine. In that position, you do the pinroll test. That is, you place the flat of the palm over the thigh and roll the limb inwards and outwards and see the position of the foot or patella, which it makes with an imaginary perpendicular to the couch, right? At the level of foot or at the level of patella. But more than that, more accurate than that is this position when the patient lies down prone on his stomach, right? So in this position, when you rotate the limb with the knee flexed, you can directly measure the angle of the leg which it throws with the couch, right? When the knee is looking inwards, it is internal rotation, right? And when the knee is looking outwards, it is external rotation. So beware, right? The foot is looking outwards. This is not external rotation. The knee, you look at the knee when you look at the rotations. So although the foot appears to be outwards, the knee is looking inwards. So this is internal rotation and this is external rotation. And as I already told you that rotations in flexion will be more as compared to those in extension because now the capsule is more relaxed, right? Now coming to the last part of the examination, that is measurement. Now measurement, as I told you that hip joint is a deep joint, therefore we cannot measure its joint line. That is why there is a concept of apparent length. So apparent length is measured from the xiphisternum or a fixed point which is proximal to the hip joint, right? A fixed point which is proximal to the hip joint. Anything can be taken from there to the medial malleus, to the distal tip of the medial malleolus, right? This gives us the apparent length. Now, apparent length is the compensated length. Compensated length is what? On which the patient is walking. Another indicator of limb length discrepancy is this Galeazzi sign. When you ask the patient to lie down with hips flexed to 90 degree and heels touching the butts, right? You can compare both the levels of both the knees, right? So this difference in the level will give us the limb length discrepancy. However, when you want to measure the true length, you have to scare the pelvis, right? When the patient is lying down, you scare the pelvis and you measure from anterosuperior iliac spine to the distal tip of the malleolus. Or when the patient is standing, what you do is that you keep a block, a wooden block underneath the foot so as to equalize the level of the ASI spines, and then you measure the lengths. So to measure the true length or the real length, you have to equalize you have to scare the level, you have to scare the pelvis. You have to bring both the ASI spines to the same level, whereas an apparent length is taken without scaring the pelvis. All right. Now, once we have detected that there is a limb length discrepancy, we must know whether it is supratrochanteric and infratrochanteric. Why do we want to know that? We want to know that because supratrochanteric limb length discrepancy indicates a intra-articular hip joint pathology. Infratrochanteric limb length discrepancy indicates a pathology which is outside the hip joint. Got it? That is why it is important to differentiate the supratrochanteric and infratrochanteric. This is known by Bryant's triangle. We had already drawn a digital Bryant's triangle earlier during palpation. Now we draw a, a true Bryant's triangle, right? So how do we draw it? This patient is lying down supine, right? This point A is ASI spine, and we throw a line vertical down perpendicular to the baseline. Okay. Then we take tip of the greater trochanter. We join points A and C, that is tip of greater trochanter and ASI spine, and we throw a perpendicular to the baseline, and then we join C and point B. Right? We extend this line from C perpendicular to the line AB. Right? So the distance in between B and C will give us the measurement in between ASI spine and the greater trochanter. All right. So if this is equal on both sides, that means there is no supratrochanteric shortening. If the greater trochanter is migrated proximally, suppose the tip of the greater trochanter is over here on the affected side, and on the normal side it is this. That means that on the affected side there is supratrochanteric shortening, and that means that there is an intra-articular pathology of the hip joint, right? So that is that is how to draw a Bryant's triangle, and that is its clinical importance. Now, supratrochanteric and infratrochanteric can also be deduced by making a Shoemaker line or an Ellerton's line. Now, how do we draw a Shoemaker's line? Is that the patient is supine. So this is the tip of the greater trochanter, and this is ASI spines. When we join the tip of the greater trochanter and ASI spine, normally these two lines should intersect at umbilicus or above umbilicus. Now suppose there is supratrochanteric shortening on this side, on the right side. The trochanter lies down here, right? Now if the trochanter lies down here and if we draw a line from greater trochanter to ASI spine, it will cross the other line below the umbilicus. All right. So that is the importance of Shoemaker's line. However, to interpret Shoemaker line, there should be only involvement of one hip. If there is involvement of both the hips, the Shoemaker's line cannot be drawn because then it will be fallacious. So for such cases, we draw Nelliton's line, which is independent of the other hip. How do we draw Nelliton's line? The patient lies down on his side, right, with the hip in 90 degree of flexion, adduction, and internal rotation. This is ASI spine, and this is ischial tuberosity. When you draw a line joining ASI spine and ischial tuberosity, the tip of the greater trochanter ideally should lie at it or below it. When there is supratrochanteric shortening, the greater trochanter lies above this line. This line is independent of the other hip, and that is why it is more important to draw an Ellerton's line than Shoemaker's line. Okay. Now there are certain tests for stability of the hip joint. Now looked for we have looked for the spatial relationship of the hip joint. We have looked for any painful condition, swelling of the hip joint. We have measured also. Now what remains is stability of the hip joint. Stability of the hip joint was seen by Trundleberg test. In cases when the Trundleberg test is not possible, we can go for telescoping and SLR. Now, what is telescoping? Telescoping is simple. You hold the pelvis with one hand and you hold the limb at the level of the knee joint or at the level of proximal distal thigh with the other hand. If the hip joint is unstable, you will be able to demonstrate a pistoning movement in and out of the hip joint, right? If the hip joint is stable, you will not neither be able to pull it nor you will be able to push it. However, if the hip joint is unstable, you will be able to pull it as well as you will be able to push it. This pistoning movement can be palpated with the other hand and is called telescoping. This demonstrates that this hip is unstable. The other test which demonstrates instability is straight leg raising, active straight leg raising, right? For a straight leg raise, you need active muscles, active quadriceps and active iliopsoas muscle, as well as an intact hip joint, a stable hip joint. If any one of these conditions does not exist, the patient will not have an active straight leg raise. Otolani and Barlows are tests for instability in small children, in infants, right? So you know that in small children, they may have a condition called developmental dysplasia of the hip joint, right? That means the hip joint is not in the acetabular socket, but it is lying posteriorly. So what is Barlow's test? Barlow's test is a provocative test. So it tends to it tends to involve adduction. In adduction, this hip joint will be dislocated, and in abduction, this hip joint will be relocated, will be reduced. So this click of dislocation, which happens in adduction, is called the Barlow's test, and this click of reduction, which happens in abduction, is called Otolani test.
Uh, we'll give Sir 2 more minutes to rejoin. I think there is an issue with the internet connectivity. Please stay with us. Dr. Sood is trying to rejoin the session into the session. Please be patient with us. Thank you. While we wait for Sir to rejoin, we will share a few questions for you all attendees. Please answer them in the next 20 seconds, and later we'll ask Sir to follow these questions up with brief explanation.
Uh,
You can start,
Sumita,
please.
Sumita, we have Dr. Sood again with us.
Yeah.
He's,
Okay, sorry, Sir. Please continue.
So let's go for the polling questions, right?
uh,
Is that okay?
That is fine. Shruti, please.
Okay. Yeah. I'm sorry for the, I don't know what happened. I'm sorry for the glitch. right? But I had covered most of it. I was on the last few slides, and let me see. Yeah,
So if you could just share your slide also with the audience.
yeah. So
So to your audiences, we will now launch the pollings for all of
yeah,
you to take up, and
yeah.
you will be allowed a 20 seconds time to answer each of the questions. And Dr. Sood will come back to you with an explanation right after that question. So here is the first poll on your screens.
Uh, Shruti, am I audible? I'm not able to see the question.
Yes, sir, you are audible, and
Yeah.
I am going to share the results. Just let
Okay.
me know if you are able to see the results,
Yeah.
and share your screen also, as we are not able to see your screen.
You're not able to see my screen.
No, sir.
Okay.
Here are the polling results. Can you view them?
No, I can't.
Okay, so sir, I will just read it out for you. The first question
Okay.
is primary extensor of the hip joint is, and there are four options: gluteus minimus, gluteus medius, gluteus maximus, and
Yeah,
the fourth is quadris femoris. So the 62% of our audiences today have voted for gluteus maximus.
that's right.
Yeah,
That's
so
right.
would you like to share an explanation behind that?
See, gluteus, am I audible to all?
Yes,
Yeah.
sir, you're audible.
So gluteus maximus is the primary extensor of the hip joint. Gluteus medius is an abductor. We all know gluteus minimus is an abductor because it is anteriorly lying, and quadratus femoris, although it is posterior, it is an external rotator. So gluteus maximus is the right answer. That's right.
Here is the second question from today's poll.
Yeah. Yeah. Am I audible?
Yes, sir.
Yeah. So what is the answer?
Yeah. Uh, Here are the results. So the question here is the neck shaft angle in adults is 15 degrees, 20 degrees, 120 degrees, or 127 degrees. So 44% of our audiences today have answered 127 degrees.
Yeah, that's the right answer. See, 15 degrees is the anteversion of the femur, right? 20 degrees is the acetabular anteversion. And 120 degrees, if it is 120 degrees, neck shaft angle, it is coxavara. So correct answer is 127 degrees. Yeah,
So
that's
are you able
correct.
to view the polls on your screen?
Yeah, I am.
All right. So I will be launching the polls. You will be able to view it and you take up the questions yourself now.
Okay,
All right. I'll launch the third question now.
okay. Yeah. So the common age for Perthes disease is under 1 year, 1 to 5 years, 5 to 10 years, 10 to 15 years. The common age of Perthes disease is 1 to 5 years. Uh, yes, that is the correct answer, right? See, this is the best answer of these four. The question has been formatted in that style. Under 1 year, it is DDH, right? 5 to 10 years, it is KIFI. 10 to 15 years, it is tubercular arthritis. 1 to 5 years is the right answer. That's okay. Yeah.
Here is the next question.
Yeah. In Trelleborg Gate, somebody is calling me from the group chat. Is that allowed?
That is not allowed.
Yeah, Devika Kapahi is calling from group chat. Okay. Anyway, so in Trelleborg Gate, the lurch is towards the normal side, affected side, both sides, or there is no lurch. That should be very simple. The affected side. That's right. So as I explained you in that slide, right, the tunnelberg gait, to compensate for the dipping of the pelvis, the patient lurches on the affected side, right, not on the normal side. Okay. Next question. Which test is recommended to measure the flexion deformity in both hips? Thomas test, Ludloff test, Galeazzi test, Stylus test. This should be very simple, very straightforward question. In both hips. So this is wrong. I'm sorry to say. Thomas test is done when there is flexion deformity on the single hip. See, the question is flexion deformity in both hips. So you are going to use the test where the patient lies prone on the edge of the table with both the limbs dangling down, right? So that test was Stylus test. So the Thomas test is done when there is single hip involvement. When there is two hip involvement, it is called Stylus test, right? So Galeazzi test is for to test the level of both the knees, right? Limb length discrepancy. And Ludloff test I could not cover Ludloff test because of this glitch, but it is Stylus test, right? Okay, next question. To scale the pelvis in abduction deformity of the right hip, so which maneuver is done? Left lower limb is abducted, right lower limb is abducted, left lower limb is adducted, right lower limb is adducted. Right? Now read the stem again. To scare the pelvis in abduction deformity of the right hip. Okay. This might be a bit tricky, but I was able to explain it to you. Oh, this is wrong. Okay, so that means that most of you have not been able to understand it. See, if the right lower limb, we have to see, we have to scale the pelvis in abduction deformity of the right hip. So when there is abduction deformity of the right hip, that means the pelvis on the right hip is dipping down. The ASI spine is downwards, right? So how do we reveal the abduction deformity? You put that limb into that much of abduction where both the ASI spines are now at the same level. So it was like this, right? This is the right side. This is the left side. This is abduction deformity, right? Down. So once you want to reveal it, you abduct it like this till this reaches the same level. Okay. So the correct answer is right lower limb is abducted, right? So if most of you are answering this, then that means that most of you have not understood it. Okay, next question. The line joining ASI spine and the tip of greater trochanter in supine position is called, this is very straightforward. Yeah. The Kynes line, the Shoemaker's line, the Nelliton's line, the Kotharis line. Yeah, that's correct. So most of you, almost 50% are correct. It is the Shoemaker's line, as I told you. The Kynes line is, the Kynes lines are the two lines. The one joining the SI spine, the other joining the greater trochanter. When they converge, it is abduction deformity. On the side it diverges, it is adduction deformity. The Nelliton's line is the one which is drawn with the patient on his side. And Kotharis line is again similar to Kynes line, which is a method to know what is the angle of the abduction deformity or adduction deformity. So it's Shoemaker's line. Next. Apparent shortening may be seen in adduction deformity, abduction deformity, internal rotation deformity, external rotation deformity. Now this might also be a bit tricky, but this will test whether you have understood it really or not. see, this is again, I don't think you have understood it very well. Now, when there is, now just look at my these two fingers. When there is adduction deformity, the pelvis goes up, isn't it? So when the pelvis will go up, the lower limb will also move up, right? So until unless you have scared the pelvises, the apparently this limb which has moved up will appear to be short. So the correct answer is adduction deformity, right? Next question. One of the following is not a test for hip joint stability. So this is very straightforward. One of the following test is not a test for hip joint stability. Trendelenburg test, SLR test, telescoping test, Thomas test. Yeah, that's correct. So it requires no explanation because I had already explained to you in detail the Trendelenburg test, SLR and telescoping. All these three are for hip joint stability. Thomas test is for fixed flexion deformity of the hip joint. Yeah, Bryant's triangle is used to detect supratrochanteric shortening, extension deformity, external rotation deformity, apparent shortening. So again, it is a very straightforward question. Yeah, so most of you have understood it, right? It is for supratrochanteric shortening because it is it gives you the real shortening. It is not apparent shortening. So that was the only caveat. And extension deformity, obviously, it is not there. External rotation deformity, obviously, it is not there. So it's a test for measurement.
With this, all our questions for the day are over, sir.
Yeah, I'm happy that except for two questions, all other questions were rightly answered. And that means that most of you have understood the concept behind hip joint examination. So if there are any other question and answers, and if the time allows, we can take them.
So, can I request you
Yeah.
to go on to
Okay.
the Q&A tab? We have a few
Yeah.
questions there.
So we have one question. How do we check the stability of hip joint if there is sacroiliac joint disease and the hip is painful, as it can produce false positive Trendelenburg test and telescoping will be relatively contraindicated? Yeah, this is actually a very good question, and somebody asked, the student has examined such patients, and that is why she or he is asking this question. Now, in such cases, yes, stability, to look for stability of the hip joint is a big question mark, right? Now, stability is the third factor. The first factor is pain. The second factor is limb length, and the third factor is stability. When all these three factors are present, right, then it is the pain which predominates, right? If suppose we take out pain and there is shortening and instability, then we can make out instability. But if it is overshadowed by pain, then none of the tests for stability can be done, and you can say in the examination that it was too painful to look for Trendelenburg test or SLR, right? I must congratulate this person who has asked this question. He or she has a very in-depth knowledge of hip joint examination, right? There are no more questions over here.
Actually, there are, sir.
Yeah, I can't see.
So the next question is asked by a person called Karthika Sinivasan, and she's asking, please explain vascular sign of Narath.
Okay.
I don't know
Okay.
that.
So vascular sign of Narath, Kartika, is see, suppose you are examining a normal person. Now just imagine in your mind that the femoral arteries, the femoral vessels are lying on the bed of hip joint, right? It's a bony bed. So once you are palpating even your radial pulse, you are palpating the artery against the radius, the bone. Similarly, the femoral pulses are palpated against the bony bed of the hip joint. If the hip joint is not present, it is destroyed, or when the hip joint is dislocated, so that bony bed is absent. So femoral pulses are there, but the surface against which they are palpated is not there. That is why the volume of the pulse will be less. So once the volume of the pulse is less, it is called vascular sign of Nareth positive, right? I hope I am clear. Next
So,
question.
sir, we have
Somehow
another
I can't
question.
see. Yeah, I can't see questions over here. So you can ask. Yeah.
Sure. What would crackling voice in the joint mean?
The crackling voice in the joint is what is called crepitus scientifically, right? So the crepitus, when it is there, it indicates that there is roughening of the joint. There can be loose body in the joint. There could be osteophytes in the joints. There could be intra-articular fractures in the joint. And sometimes it could also be present because of synovial hypertrophy in the joint, right? So most of the times, these crackling or crepitus is present in large joints, superficial joints like shoulder and knee. Sometimes it is also there in hip joint, right?
Next question, sir. How are the ligaments of hip joint affected in patients with a femoral graft?
In patients of, you're talking about total femoral graft. So see, these ligaments, some of these ligaments, they are left in the recipient, right? And these ligaments are then stitched with the help of anchor sutures to the bone. So whenever the ligaments are not there in the recipient, ligament and bone interface is joined with the help of anchor sutures. Okay.
How to determine side of G medius affected with Trendelenburg sign?
Didn't get the question. How do we?
How to determine side of G medius affected with Trendelenburg sign?
See, I explained it to you. Suppose it is the right lower limb which is suppose we go by the figure. Suppose it is the left lower limb which is affected. The gluteus medius on the left side is affected. Now what happens is that when this patient with left-sided affected gluteus medius stands with the left lower limb on the ground and right lower limb in the swing phase. So what happens is that with the effect of gravity, the right-sided pelvis dips down because his left-sided gluteus medius is not acting. Because it dips down to reduce the energy expenditure, the rest of the body lurches towards the left side, right? So where the direction of the lurch is, that side of gluteus medius is affected. Okay. So as simple as that. You have to look at the side of the lurch. If it is left side, it is left-sided gluteus medius. If it is right side, it is right-sided gluteus medius. Yeah.
Question: how we differentiate between rheumatoid arthritis and fibromyalgia?
And fibromyalgia.
Right.
See, this is not a question pertaining to this topic. Rheumatoid arthritis is specific, it's a specific disease. Fibromyalgia is a different specific disease. So I don't think it pertains to the scope of this lecture. Let us stick to the examination of the hip joint.
That will be all
I,
for
I
today,
can
sir.
see, yeah, I
Yeah,
can see
please.
here Barlow's test. Please explain. So if we have time, can we go ahead?
Yes, please.
Okay. So Kartika has asked Barlow's test. So as I told you that Barlow's test is a provocative test. So what happens in Barlow's test is that you adduct the lower limb. When you adduct the lower limb, the proximal part of the femur, it comes out. Okay. So hip joint comes out in adduction and it goes in abduction. So when you do a Barlow's test, you provoke the hip joint to come out by doing adduction and placing the femur, placing a posterior pressure on the femur, right? So once the hip comes out, there is a click of dislocation. That is Barlow's test. And when you abduct this hip joint, that is you try to reduce the hip joint, there is another click of reduction. That is called Ottolangi's test. Okay. Now there is another question. A child with pain on squatting, how to proceed, sir? With pain on squatting, how to proceed for what? Okay, this question is not clear, so I'm not taking it. There is another question, waddling gait. Waddling gait is, bilateral Trendelenburg gait, right? So the patient, because both the hips are unstable, he waddles to this side, left side, and then next he waddles to right side. On each stance phase, he keeps lurching to If the stance phase on the left side, he lurches to the left side. The stance phase is on the right side, he lurches onto the right side. This gait commonly happens in bilateral, untreated dislocations of the hip joints. Okay, there are no more questions.
Okay, so this brings us to
Yeah.
the end of today's session. Thank you, sir, for this interesting lecture and
Thanks.
Q&A session.
Thank you.
My fellow participants have gained a lot from this. Thank you, participants, for attending the session today. Have a very good evening.
Thank you very much. Thank you very much. We'll meet again. Thank you.